welcome to yet another very exciting episode of the Maternity Show on African Renaissance TV with me, Sohna Gaye. And today on this episode, we are going to discuss a very important topic, of course, pregnancy and its complication. Who is going to discuss this with us? This is a vibrant young lady in the Gambia working with MRC as an assistant nurse coordinator. Of course, we have Sohna Gaye in the building to discuss pregnancy and its complication with us. Sohna, you're welcome to the Maternity Show.
Thank you so much for having me here today.
Thank you, Sohna, for honoring our invitation.
It's a pleasure.
So we are going to talk to you in two dimensions. We're going to talk to you as a nurse. I mean, you have a vast experience in terms of nursing in the Gambia with a background in nursing and, of course, in public health. We are not going to forget that part. And also as a mother. So before we go into the discussions proper, we will need to understand what really we are looking at when we discuss or when we mention complications in pregnancy. So take us through, what do we mean by complications in pregnancy?
Okay, thank you, Sohna, for having me here this afternoon. We're talking about something very important, and it's one of the things that we look at every day in our work as nurses, in our work as public health officers, in our work as caregivers in any facility that you find yourself. When we're talking about complications, there are a vast number of complications in pregnancy, but there are some that are minor. We categorize them under minor disorders, and some that are major complications. So when we are talking, because each of these two categories have different ways of managing them.
Sure.
So when we talk about the minor complications, these are the minor ones that you can even take care of at home level, except it is moving from minor getting to more severe one. Let's say, for example, vomiting. Vomiting will be considered a minor complication in pregnancy because due to the changes in hormonal imbalance, that will lead you to start having vomiting, especially in the early hours of the morning. But when it becomes excessive, that will now categorize it from, move it from a minor disorder to a major problem. And when it becomes major, it's going to be a hyperemesis gravidarum. That is excessive vomiting in pregnancy, especially in the first trimester. That is the first 3 months of pregnancy. So usually what happens is the person or the woman vomits everything that she eats.
So interestingly, it becomes one of the things that somebody would just point out and say, this woman is pregnant because she's vomiting. So, and most of us will think it's very normal to vomit while you're pregnant, and we need to understand that excessive vomiting should be reported to the nearest care health facility. Is that the case?
It shouldn't only be reported, but should be taken care of at a tertiary level, or even at our minor facilities, because such women, they're not able to tolerate food. So one of the first line of management that you will want to do is make sure this woman have a continuous rehydration, that is giving this woman IV fluids, at least to have an electrolyte balance, since there are a lot of hormonal changes that are taking place in the pregnant woman. So you wouldn't want the woman to not be eating because they're not tolerating food. So they need to have the IV fluids given to them, at least to sustain them.
And the baby.
Yeah, and the baby.
Yeah. So quickly, let us look at other complications that a woman would go through while she's pregnant.
The major ones that we see, there are different complications, like I said, and the major ones that we see, especially in one setting in the Gambia here, I first want to talk about hypertension. That is an increased blood pressure more than normal, and some books will tell you the normal would be from 90 to 135, depending on the school of thought. Others will even go to 140, but we all understand 140 is the margin. Yeah. So anything beyond that normal blood pressure reading is categorized under hypertension. So it is one of the commonest complications that we see in pregnancy in the Gambia.
Wow. So hypertension, earlier on some of our episodes we did highlight that it could be as a result of lots of risk factors that will be there. So apart from hypertension, what other problems do women face? I know that infection is key among the complications. Let's look at infections as a complication of pregnancy. What would you have to say to the women out there with regards to infections that they come across when they're pregnant?
For infection, specifically, I think it's important we talk about the urinary tract infection, which is one of the things that women undergo through the whole period of their pregnancy. Some of them, they have it at the earlier stage, but others towards the end of the pregnancy. That is when they're in the third trimester, they start experiencing some of the symptoms of urinary tract infection. And some of these symptoms will be like they have a difficulty passing urine. Some of them, they have the urine will have an odor, and some of them they develop develop itching, that is vulval itching. Some of them, they have blisters around the vulval area. So, all these symptoms will be accompanied with lower abdominal pain. So usually when you're at the antenatal clinic and you come across such women, you will want to send them to the laboratory where they will have to do a urinalysis or a urine dipstick that will look at the presence of leukocytes. This will determine whether it's a bacterium, whether there is bacterium infection, and we will look at the glucose level in the urine. We will look at the protein level in the urine. We will look at the bilirubin, because all these parameters that you're looking at will pinpoint to something that is happening within that urinary tract lining. So it's important you do those things.
So what causes this?
There are different causes to urinary tract infection. Some of them are bacterial infections, bacteria, microorganisms. Bacteria causes urinary tract infection. Fungus causes urinary tract infection. But sometimes some of these urinary tract infections are not even caused by microorganisms. Instead, it is caused by us. When I mean caused by us, that is our hygiene, our level of hygiene.
Yeah.
Sometimes, especially in this era of the tight trousers they put on in the name of ties, sometimes people wear them for like 6 hours, 8 hours without changing. And most of these underwears that we put on, some of them are nylon. And when it is when you wear this kind of clothing materials, especially underwears, for such number of hours without changing, and the vulval area is not kept clean all the time, these are the things that would attract microorganisms. So sometimes it is our personal hygiene that will even attract these microorganisms, because you have the flora and fauna that are very normal in the vaginal area. But when they are tampered with, example, you change the nature or the temperature of that environment, because we know that nylon materials, they tend to increase the temperature because they attract heat. So when such happens, you're altering the normal environment, the normal habitat of these microorganisms. So when their habitat is being altered, then they will start, instead of them being a normal commensal on the body, they will start reacting, thinking that heat is a foreign body around that vulval area. So they will start attacking the normal cells. They will start attacking anything that is within that area. So this attacking that they will do, so the body will have that reaction of producing an itch, or there would be some reddish blisters around the area, and this might be there might be an ascending infection, whereby the infection will be coming from the vulval area going through the urethral canal. So with that you start seeing severe complications like lower abdominal pain.
Wow. And could this be translated from using like one let's say toilet by several people as well?
Using toilets where different people are, usually I think some people, they categorize it under the medical mites. That is, we don't think some of these microorganisms live in the environment with us. We understand that, but how close is that vulval area to the toiletries that you are using? This is the question that we need to ask. So it's just a belief that some people, they believe, some scientists, they believe that this is not true, that you can get infection through the toilet, but then our environment contributes a lot to our health. Sure. So it's safer to use a toilet that is less used by people if you don't have your own. But if you're in a public domain and you need to use yourself, obviously you will use. But what is advisable is for you to get an antiseptic liquid with you always, where you can have to wipe the area
before you use it. Nice. So looking at infections again, it's worrying, right, for women to go through infections while they are pregnant, because remember, these are two lives walking on the streets and people are watching them. So what happens to the woman is clear, but now what happens to the unborn baby when the woman is infected?
Good. It is good, sometimes the way nature does its things. The best news that I can give you is that most of these urinary tract infections, if not all, they only affects the woman, because very few are the ones that can pass through the placenta, because the placenta is the barrier between the mom and the fetus. So though there is what you call fetal-maternal circulation, there is blood going from the mom to the unborn child, and from the unborn child back to the mom, because whatever the nutrient, the blood supply that the fetus is getting is from the mom. So but the placenta serves as a barrier for all these infections. So usually it stops with the mom and not getting to the fetus.
So let's say, for instance, this gets severe with the mother for certain bacterial infections. And at the end of the day, would this affect the baby in terms of the weight, if it's not controlled or managed at facility level? Or, because I was thinking, I stand to be corrected though, that most of these things are the ones responsible for babies being born with a low birth weight, or of course having premature delivery, stuff like that. But maybe we can look at that at a later side when you discuss other complications different from infection. So that would be cleared for us. So let's just move on to the other side of the whole show, the whole episode now. We've looked at infections and how this infection affect women and then their babies. Bleeding is also another complication that women go through. Let's discuss bleeding. Is it normal for a woman to bleed when she's pregnant or not?
Good. Different people have different thoughts regarding bleeding, but bleeding generally, any bleeding at any stage of pregnancy is termed as a danger sign. If a woman is pregnant and there is nothing like implant bleeding, then any bleeding that you see is a danger sign to the woman, and what the woman needs to do is to sought medical help. This implant bleeding that is being referred to in books, that is the woman is already pregnant or the woman has already conceived, but then there are residual in the cervical area. So this residual will have to come out, and it can only come out through the vaginal opening. So this will look like a menstrual flow, but then implantation has already taken place. So this blood residual will have to come out. So some women, they experience this in the first trimester, and they can see it for the first month, they can see it to the second month, to the third month, but still it doesn't make it normal. And when this becomes severe, the woman needs to go and seek for medical help. Even at the first type of bleeding, bleeding in any stage of pregnancy is a danger sign.
So how would we manage bleeding now?
There is something that is called antepartum hemorrhage, that is bleeding during pregnancy or before delivery. So, and this is caused by two major things. Usually we have placenta previa and placenta abrupta. These are the two main causes of bleeding, if it is not an implantation bleeding. So with placenta previa, what happens is the placenta that I made mention of earlier, instead of being at the normal place where it is supposed to be, at the posterior level of the cervix, it comes and attaches itself towards the opening of the vagina. So it is not at the normal site where it is supposed to attach. So when this happens, as the pregnancy is progressing, since that place is not the normal site of attachment, it tends to erode. It will start moving from that place. So when it moves, it will cause, there will be bleeding, though it is going to be minimal. So this is how we even differentiate whether this is a placenta previa or it is a placenta abrupta. Because with placenta previa, the bleeding is very minimal, because it's only a detachment that has happened, and then and it has different stages. It has, some books will tell you 3 stages, some books will tell you 4 stages, depending on the attachment. But when it is a complete previa, that is a complete opening of the cervix, is being covered with this placenta, and with such, for the woman to deliver vaginally is going to be difficult. So usually it is opted for a cesarean section, an elective cesarean section. So in placenta abrupta, you have more bleeding than in placenta previa. In abrupta, what is happening is that the placenta detaches from its site where it was since the onset of the pregnancy, and start moving around in the uterus. So when that happens, because it is a highly vascularized organ in pregnancy, the blood starts flowing out, and this is accompanied with not only blood but also blood clots, because we know the placenta is highly vascularized. So these are the two. Bleeding is one of the two things that you look at to differentiate whether it is abrupta or placenta previa. So antepartum hemorrhage is the key thing that you looked at in bleeding in pregnancy.
Yeah, so quite interesting. And let's make use of your experience as a nurse, in the facility. Women would usually come to you with several complaints and all that. So what other complications would they complain of apart from bleeding and infection?
Usually the most common, because we have what we call the baseline protocols. When a woman comes to the clinic, that is on the day of their first visit, usually you take them around from registration with the antenatal card. You have to do their vital signs. Then from their vital signs, the next most important thing is to send them to the lab. So and at the lab, their hemoglobin level will be checked, and then urinalysis will be done. So it is the baselines that of what you are supposed to do. So with this urinalysis that is done at the lab, usually it picked up something, especially like things like leukocytes, which is looked at with the urinalysis, because it is this leukocyte that is pointing at infection. So you looked at leukocytes, and you will want to know how many pluses of leukocytes, whether it is a 1+, which is less severe. If it is a 2+ leukocytes or 3+, then you will need to give, even with 1+ in pregnancy, what we are going with is to give that woman an antibiotic treatment. And usually the first line of choice, depending on the severity or depending on associated things that you will look at, usually we give amoxicillin for a period of 7 days, and we give it every 8 hours in a day.
Nice. So would we be correct to mention that anemia, it's also another complication that women go through? I mean, we will have to answer this question when we are back from the very short break. But for now, let's just go on a very quick break, and we'll be back shortly. Welcome back from that very short episode focused on pregnancy and its complication, of course, with Sohna Gaye. So before we went on that short break, we were trying to discuss on anemia as one of the complications as well. So let's look at it, because in a previous episode we discussed on anemia, but as part of the complications, women need to understand that anemia is also a complication. So how does this affect them?
It affects them a lot, and like I said, with the baselines of the first things that you have to do when a woman reports to any health facility, your hemoglobin level is one of the things that is looked at too. And then with that, whether it is at a lower level depending on the reading, because anything less than 6.5 according to WHO is categorized as anemia.
Yeah, but we will have our fullest to look at that again. Because women, I mean,
they are special.
Yeah.
Talking about anemia, plus are very special.
We will agree with that.
I don't want to mention tribes here, but what one tribe may have, and it will disturb them, and you will be very worried. You may have a fuller with lesser HB, and you wouldn't be worried about it. So
I wonder when women come to the facility and they are with HB of around 4, and they're still able to go through it and give birth. Oh, that's scary.
Yes, they are just amazing, and I think our scientists, our researchers will have to
answer that
as to why fullers are so married to anemia, and it doesn't affect. It affects them, and you see some of them with terrible complications. But then most of them do survive anemia throughout pregnancy up to the time of delivery, and then you just need to put them on FIFO and they are good to go.
No.
So with regards to anemia, it's one of the key most important things that you look at in a pregnant woman. Because we know with delivery the woman must bleed.
Yeah.
So with that bleeding that you are foreseeing, that because it is 100% possibility that this woman is going to bleed. No matter how minimal, there will be bleeding during delivery. So you don't want to risk that woman going with that low HB up to the time of the trimester towards her delivery, towards her time of delivery. So you want to rectify that. And usually they are giving FIFO with other vitamin supplements that they will have to take. And then at least every 2 weeks or 3 weeks, you need to send them to the lab where they will have their hemoglobin level being rechecked, because you want to make sure they have a good hemoglobin level before they get to the 3rd trimester.
Nice. So who are really exposed to, I know every pregnant woman must go through 1 or 2 complications, but what risk factors are we looking at for a woman that is pregnant to go through most of these complications?
With complications in pregnancy, especially with the major ones, we will want to look at age, because when we're talking about age, we're talking about the elderly. Anybody who is beyond 40 years will experience, though some women are more than 40 and they go through normal pregnancy, give birth with no complications. But then if you are more than 40, you're still in the childbearing age, but you attract more obstetric risk
Really? I thought we were looking at 35 upward. Oh, I'm missing it.
Will tell you even 35. Some books will tell you. Some people, some OBGYNs will tell you 35.
Yeah.
But then when you get to 40, that is, it's really an alarming age to be associated with pregnancy. And then those that are under age too, we're talking about the teenagers. Though we see some of them going through pregnancy normally, and even end up having a normal vaginal birth and without cesarean section, but still that doesn't exempt them from the associated risk. So age is one of the things that you looked at with associated risk factors. You want to talk about hereditary. These are things that we get from our parents. And with hereditary, you want to talk about the gestational diabetes that we see very often in our clinics now. You want to talk about the eclampsia. That is because when you have the pregnancy-induced hypertension, it goes through stages. So from the pregnancy-induced hypertension, it gets to the pre-eclampsia. Then from the pre-eclampsia, it gets to the eclampsia. So even if you look at it nowadays, people will say in our facilities there are a lot of cesarean sections that are going on. But what people don't fail to understand is that they don't look at these risk factors that are leading to this high number of cesarean sections that we see in our tertiary facilities.
So maybe I belong to the group that feel that cesarean section it's a choice. A woman that does not want to go through safe vagina.
Yes, it's a choice, because that is yes, it's a choice. There are some women who don't want to undergo vaginal delivery, so they have a choice of getting a cesarean section in any of the tertiary facilities done, and it's not a crime to opt for a cesarean section.
But what is advised is for a woman that is having complications to go through it. Is it advised for everybody to go through it, or is it just for a woman that is having complications to go through cesarean section?
Like I said, it is a choice. If you don't have any problem, it is a choice of you wanting to do cesarean section or not. But when you have certain complications, let's take for example pre-eclampsia, where the woman's consciousness level will go down, and when the woman has an eclamptic fit or an increased blood pressure, we know with delivery, you need energy to do that. So when your blood pressure is already elevated, it is skyrocketing. You wouldn't want that woman to go through that stress again of pushing a baby out. So what the first choice that you have is to send that woman to the theater and get that baby out. At least because when you do this, it is what is helping the woman to lower down the blood pressure. So it's one of the choices that that an OBGYN will use to get the blood pressure down.
Who is an OBGYN?
That's an obstetric and a gynecologist.
Oh, okay.
Obstetrician and
gynecologist. Because we are getting confused already with the terms here.
Yes.
So what other risk factor are we looking at apart from age and heredity? Do we have any other?
Yes, disease conditions. Disease conditions like sickle cell. We do not say sickle cell should not get pregnant because that would be very dangerous to utter out. But then they need to be guided throughout their pregnancy. They need continuous monitoring. They need, especially with their hemoglobin level, because we already know they have a sickle safe instead of the normal biconcave safe of the red cells. So we didn't want them to get into that difficulties, because most of them, even they must have, most of them, in most cases, they have abortion.
So I mean, sickle cell is really a topic I want to discuss because it's a big concern for me. I know some colleagues that are having it. I want to have a special topic on sickle cell and how these people manage this. Well, it's interesting, but if we want to bring it up here, it's going to take our time. But I'm really interested to know more about sickle cell and all that.
Because even those that reported, those that we see at the clinic with SS genotypes, that is the sickle cell genotype, usually they are given greater attention by sending them to the special care clinics at the MOPDs or at the gynae clinics, where they will be seen at least every week to make sure things are going fine with the woman
baby
and the baby as well. So sickle cell is one of the things on the disease conditions that we looked at as some of these factors, these associated risk factors. We also want to talk about, apart from sickle cell, there are other disease conditions too that may, where you can get, let's say, the carcinogens, the cancers. You don't want to expose the woman who is already battling with her health to be exposed to pregnancy again. Then there would be too much burden on that woman.
Would HIV be categorized under this? HIV?
HIV is not categorized under the risk factors.
Okay.
Though, because we have that is the PMTCT, the prevention of mother-to-child transmission. So with this PMTCT, it is helping HIV mothers to get pregnant and give birth safely. Though there are chances of the mother infecting the child, but the chances are very, very minimal.
Okay, that's nice. So let's let's say I am a pregnant woman here. I pray to be pregnant one day.
Before you get to that, one of the other complications that we see, or one of the risk factors that we see in the Gambia here, is the female genital mutilation.
Yeah.
It's very common in our facilities, and the saddest part of it is that though there is an act of parliament that have enacted a ban on the FGM, it is still happening in our country, and it is important we talk about it. And usually what we see, most of our, not all, but most of our women who undergo cesarean section, some of them are categorized not only the type 1 or type 2, but type 3. And we are even seeing type 4, where the whole vulval area is being cut off. So it's one of the leading causes it's among the leading causes of cesarean section in the country. It's among the leading causes of maternal mortality in the country
as well.
So I think it's important. Anytime we have the opportunity,
we will have a whole
women, the young mothers that are coming, not to send their children or their daughters through the same thing that they have gone, because we have our cultures, we have our beliefs, but then if something is giving you more risk than it benefits you, I think there is time we looked at it. People have been talking about it over and over again, and it gets more serious that an act of parliament was enacted because a law was put on in place. But how do we monitor people that are still doing it in our neighborhoods, in our communities, in our villages? How do we monitor them to make sure that the results are thrown away, not only put down, but they are thrown away from our daughters? So
we will have that, and it will really be interesting if we go through some women that have gone through this and then explain their own stories, so that other women that still think it's okay to have a lady go through FGMC would really understand what those that have gone through it enjoyed from it. So before we move ahead to really understanding the key players in managing complications in pregnancy, how would I know, like I was trying to say, when I'm pregnant, that I have complications?
Good. Most of these major complications, they have warning signs. And these warning signs, they keep alerting you. And the saddest part of it is that that is going to be our next point of discussion. Yeah. But then in trying to figure out this too, I think I would just want to say, but I will say this later.
Okay.
Some of these, the warning signs that it will send to you is headache. I'm not saying every headache is a warning sign, but then when you have a continuous headache that is not subsiding, throughout the day you have a headache, before the day ends you need to visit a health facility, because it might be alerting you of an increased blood pressure.
And not to take paracetamol on your own.
Take paracetamol on your own,
because that is
medication.
Yeah, exactly.
Even paracetamol contains some active ingredients that not just anybody should just take and introduce into your system and be giving more work to your liver to be doing. So it is advisable that when you are pregnant and you have a headache that is just not out of fatigue or out of being stressed, please visit the health facility. And some of these the danger signs or the warning signs, you have blood vision, and with blood vision this can be also related to gestational diabetes, or it can even be related to the hypertension state. You may have blood vision, and so with that too, don't just assume maybe because the sun is hot,
that's why I cannot see.
I can see clearly. Please go to the nearest health facility. The other thing is edema. Is very common where you have the swollen feet. Yeah. So this swollen feet too is also pointing at hypertension, because most of the time, most women, they have edema, they have increased blood pressure. Though there are some exceptions, those that it's very normal of them to have swollen feet. Though it's not normal, there is something that is wrong here and there, but to them it's normal because they have experienced it well before pregnancy. So when they get pregnant and it continues, they think it's normal. But then you need to get to the root cause of that edema that you have. Yeah. So basically, these are some of the danger signs that you have to look at. And bleeding, like I said, bleeding at any stage of the pregnancy is a danger sign. So you need to report to the health facility.
So would we have, let's say, a puffy face? Because naturally women would change saving body, I mean, when they are pregnant, and also this big pimples that they will have on their faces. Are those ones also sending messages that they're having complications, or those are normal things?
Depending on how you categorize the puffy face, it might be because that puffy face, if it is just a normal phenomenon from the pregnancy, usually it's early in the morning when you just wake up from sleep. Usually what some women experience that doesn't go out anytime soon during pregnancy is the change in the shape of the nose. Usually women tend to have a bigger nose when they are pregnant, and when they deliver, at least for a day or 2 or 3 days, it comes back to the normal shape. But then when you have an asaka, that is general edema, it is not only not a puffy face. sometimes you see this happening. Anywhere that you touch on the woman, it's spinning, and when you press, it goes in. That is a sign of edema because there is fluid in the interstitial fluid compartment of the skin. So what you need to do is to sort for help, to seek for help. So with that puffy face, like I said, it depends on what we are looking at. If it's only in the morning and it disappears, maybe it's due to maybe your longer hours of sleeping, your face gets puffy, but then this will disappear immediately. You wake up and have your bath or start walking around doing certain things, it goes down. But if it continues up to the end of the day, please visit the nearest facility
to help you out. So let's shift a bit from you being a nurse to you being a mother at some point. So when you went through some of these complications, what did you do at your own level?
Mine would be a very funny one.
Yeah, because you already know this is happening and this is the results of this and all that.
Yes, I went through cesarean section twice, and both of them, when I had my first pregnancy, you know what is funny is that when I get pregnant at the early stage of my pregnancy, I did an ultrasound scanning somewhere, and there was this radiologist that told me, I don't know when you're going to deliver, whether I'll be here or not, but please, when it is time for you to deliver, do not go through vaginal delivery. I just looked at him and he sounded funny to me, not knowing that he saw something that I did not believe may happen with me. Considering my size, I think I have a gynecoid pelvis. I think I have a good space, I have the strength, I'll be able to push my baby out. But then what happened was I was in labor for my cervix started dilating, and it took me 5 days before I get to fully dilated. And then I got admitted. And on the day when I visited the facility, my gynecologist advised me that I should do a cesarean section. I was like, no, I want to go through vaginal delivery. And he was like, we're going to spend a longer time here. You will stay here, and then you will end up having a cesarean section. I'm like, no, let me try. So this was how I stayed there. I was there for almost 18 hours before I finally agreed. Not I finally agreed, because then the fetus was not coming down and labor was not progressing. Imagine after 18 hours, I was still at 6 centimeters instead of getting to 10 centimeters to be fully dilated and be able to push my baby out. So this was how I ended up having CS. So the second pregnancy came, it was still the same story. I was waiting for the cervix to dilate, and then unfortunately, after 3 days of waiting, it was still at 2 cm. So my GYN was like, I'm not taking this risk again. You see, what you went through your first pregnancy is going to be the same. So there are different types of pelvis, and this has nothing to do with your age or your
body size.
The different pelvis. There are some women that have the A pelvis, that is the man pelvis. So with some women, usually what they have is FTT, that is failure to thrive. That is, your baby wouldn't have the strength to come out through that tiny opening. Instead of having that concave opening for the baby to smoothly come out. So it's a difficult. So usually the baby gets stuck, the fetal skull gets stuck, and it cannot come out through the vagina. So with such women, usually they have to undergo cesarean section, and I think that is what is happening with my case. So far so good. I had to go on.
That was so sad. Sorry about that. Anyway, so
cesarean section is not
exactly. So I believe that our male counterparts would obviously have a role to play in this whole thing, because they are the decision makers and they need to take care of their women when they are pregnant and all that. So before we quickly let you go, let's discuss on the several roles that the key players would have in controlling the complications. The role of the government, the role of the man, and the woman at some point.
Good. I think I would want to stress more on the role of the man, the father of the child, because a woman is not pregnant on her own. So it takes two. So you putting the woman through the stress of pregnancy, because we know pregnancy is not a disease condition, but it's very stressful. So having the man beside a woman is really interesting, and it's really important in the caregiving, because as they always say, 2 heads are better than one. So when you accompany your woman to the health facility, usually you're given that accord, you're given the opportunity to ask questions regarding the various investigations that your woman is subjected to, and some of the drugs that we are going to give. So even like in the Gambia here, so most of the time, women, you see, you give them this FIFA that is helping them boost their hemoglobin level. They'll prefer to put it under the mattress or just throw it somewhere in one of their drawers instead of taking it every night or every morning. depending on your time of choice.
Yeah.
So when we have the man accompanying your wife, your spouse, your girlfriend to the antenatal clinics, at least if she forgets, you'll be able to remind her. And if you see some of these complications or some of these minor disorders in pregnancy, you will be worried because you know what you have had at the antenatal clinic. Because every morning before we started the clinic, there is sensitization. We give health education to women. Every visit, every clinic, we choose a topic to discuss on. Sometimes we want to talk about hygiene, we want to talk about the high blood pressure, we want to talk about all these minor disorders before we even talk about the major complications in pregnancy. So when the man is there listening, at least the man will be a supporting system and will complement the efforts of the midwives that are at the facility. Because you are staying with your woman. So when you see certain things, even if does not want to report to the facility, you will serve as a guardian to your woman to help her get to the facility at the right time.
I mean, even mentally, this woman could be supported through it, because I know women would go through anxiety when they are pregnant and all that.
Yes, when they see their men beside them, because if you go to certain health facilities in the country, we are doing it where we encourage men to come to the antenatal clinic, even at the infant welfare clinics, we encourage them to come. And the good part of it is that in the Gambia, when we see men in our clinics,
we attend to them
first before we attend to them, because we know they are devoting their time, leaving their work or whatever they're supposed to do to come to the clinic. So we give them the opportunity. So I will use the opportunity also to encourage men to coming to the antenatal clinic more, even before the child is born, because we see them more now going to the RCH and to the infant clinic and not to the antenatal clinic. So it's important they come to their women to the antenatal clinic.
Creating our time is already off, but I wouldn't want to allow you go without saying your final thoughts on this episode. But again, we missed out one important thing, which is the role of the government, because I know the government is there to provide us with facilities. What are their roles specifically? Maybe one or two, and then we can wrap up.
Okay, I just want to say one. That is to make sure every equipment that is needed by the midwives is available on time.
Yeah, because that is important for management.
Because when we have a minor health center without a blood pressure machine at our labor wards or at our antenatal clinics, is a big problem. Because you don't know how many women you are missing that are going home with increased blood pressure. How many women are you missing not being able to attend, or some of them, even when they leave the facility, they end up falling on the street somewhere, or even going back to the market to go and get what to give to their families. So I think the main role of the government is to make sure there is continuous education among healthcare workers, and then materials that we need must be available at all times in our clinics.
Nice one. So what are your final words again that you would want to tell the women out there that are listening to you or watching you, and even the men? Just one or two things.
Okay, thank you once again, Sohna. It's rather unfortunate that we are ending this.
Exactly.
There will be other opportunities where we will elaborate on some of these things that we just pinpointed broadly. I want to say to the women, the Gambian women, to that woman in Bolibana, that is the last village where you get to the border in Senegal through URR, or the woman that is in Katong, that health professionals, our main role as health professionals is to continue educating our women, our children, our men. So education is a continuous process. It's never ending. So whenever you see certain things, especially if you are pregnant, the first thing that you have to think of, don't go to Park and Kamusa, don't go to the witchcraft doctor in the corner or somewhere in the bush. Get help first. And in getting help first means getting to the health facility, because this will help us understand your problem earlier. This will help us diagnose you earlier, and even if there is need for referral, this will help us make an early intervention of making sure you get the help at the right time. And this will help save your life. So whenever you see anything during pregnancy, please do not hesitate to get to any facility that is nearest to your home.
Well, viewers, thank you very much, Auntie Sohna, for joining us. It was really a short period, but we've learned a lot from this small 30 minutes, and we would appreciate to have you again on other issues, especially to talk specifically on some of the complications that you've mentioned here. But we will have to draw the curtains here, viewers. And Auntie Sohna did mention that we need to help them save us, and that is now our responsibility. It's not just one person show. We need to look at it as a woman, and we need to look at it as male parts as well. So everybody should come on together, the government, the male counterparts, the women, and even the society at large, to make sure we fight against some of the things that we are affected with when we are pregnant. So as we draw the curtains here on this very important episode, I want to remind you that I was your host for the Maternity Show on African Renaissance TV. And do not forget to subscribe, like, and share the videos for more interesting episodes that will come come your way. And do not forget that this show is open for partnership and sponsors.